Here we see a picture of a neonate with anencephaly. As opposed to spina bifida, which results from posterior malformations, this results from malformation of the anterior neural tube. The result is a lack of a forebrain, and this is typically not compatible with life, unfortunately. Now, what is similar to this and posterior malformations is that they are detected by a similar method. And what is that method? Increased alpha-fetoprotein, or AFP. There's also an important association with an endocrine disorder that you should be aware of. What is it? Maternal diabetes. And so you see, you can be asked about this question in a manner that deals with endocrinology, reproduction, or embryology. And you should always be looking for these types of connections between different systems, especially ones that at first don't seem obviously connected. Now this next picture is of a coronal section of a T2 weighted MRI of semi-lobar holoprosencephaly. It results from failure of the left and right hemisphere to completely separate and can be seen in the lack of a distinct separation between the two hemispheres. With this condition, you can also see a cleft lip as well as other physical deformities. Now if I told you that this disorder is due to problems with Hox gene signaling in one of the primary brain vesicles, which vesicle would you guess was responsible? Of course, the answer is the prosencephalon. Now, let's have a quick flash quiz. Do you remember the group of cells that can go on to create, among other things, Schwann cells, melanocytes, and pterochromaffin cells? The answer is neural crest cells. Now, with the amount of complex signaling required to assemble a brain, it is remarkable that things actually happen correctly as often as it does. There are so many ways that things can go wrong. Here we see two T1 weighted MRI images of malformations involving the cerebellum, Arnold-Chiari malformation and the Dandy-Walker malformation. Now, Arnold-Chiari malformations result from a cerebellar herniation, shown here. This herniation goes through the foramen magnum and can lead to a host of problems. Some key findings to look for are headache, hydrocephalus, myelomeningocele, which we discussed before, and paralysis. These would all happen below the level of the defect. An important association that can also be useful when answering questions is that patients who have connective tissue disorders that lead to instability of the craniocervical junction are susceptible to developing a Chiari malformation. Now, what are two common connective tissue disorders that could lead to such a susceptibility? Well, the big ones would be Ehlers-Danlos syndrome as well as Marfan syndrome. Just as a reminder, Ehlers-Danlos results from a defect in collagen synthesis, while Marfan's results from a mutation in the gene that codes for the structural protein fibrillin 1. Dandy-Walker syndrome results when there is an agenesis of the cerebellar vermis. This allows for the expansion of the fourth ventricle. In this T1 weighted MRI, you can see that there is a huge enlargement of the posterior fossa. The cerebellum is hypoplastic, much smaller than it should be, and the fourth ventricle is continuous with the cyst, seen here. The symptoms that are seen are wide and varied, but can include things like increased intracranial pressure, vomiting, convulsions, abnormal breathing patterns, as well as abnormal motor coordination. It is helpful to think about where problems might exist due to an abnormal cerebellum and enlarged fourth ventricle. That would put pressure against the pons and medulla and what those areas control. Syringomyelia is one of the more commonly tested neurodevelopmental disorders. It is caused by a cystic enlargement of the central canal of the spinal cord, as seen in this radiograph here. Now, syringomyelia can be either congenital or acquired, and there is an important association between the congenital form and a disorder that can lead to cerebellar herniation. Now, what disease is that? The answer is Chiari-1 malformations. The acquired type can occur secondary to things like trauma, meningitis, and tumors. The typical presentation that you will see on a question will involve a cape-like bilateral loss of pain and temperature. And this usually will happen in the upper extremities. This makes sense as the defect is commonly seen between the C8 and T1 vertebrae. You should remember that the spinothalamic tract carries pain and temperature information to the brain. The enlargement of the central canal compresses these fibers, leading to a disruption of that pathway and the information it carries. It spares the other major spinal sensory pathway carrying information about touch and proprioception. Now, what is this pathway called? That is the dorsal column medial lemniscal pathway. Time for another flash quiz! Yay! Now, what are the two proteins that can be measured as surrogates of neural tube defects? The answer to this question is elevated alpha-fetoprotein and acetylcholinesterase, and we've talked about this in 2 examples so far.
The innervation of the tongue is complex, but it can be broken down in a manner that makes it easier to remember. Now, a great part of the tongue's function is in the aiding of chewing and swallowing in addition to enunciating words. Now, all of these require motor function, and this is done by the hypoglossal nerve. Another important part of the tongue's motor innervation comes from the vagus nerve, which elevates the posterior part of the tongue. Another large part of the tongue's function is, of course, its ability to taste. This ability requires both special taste receptors as well as general sensations such as hot, cold, and texture. These functions are divided between the cranial nerves 5, 7, and 9. Now, 9 is a bigger number, so think of it as being larger and able to carry more of the burden. So it carries both taste and sensation at the posterior third of the tongue. Cranial nerves 5 and 7 are smaller numbers, so they can each only carry one responsibility. 5 carries sensation for the anterior 2/3 of the tongue, just as it does for the rest of the face. 7 carries taste information for the anterior 2/3 of the tongue as well. It does this via the chorda tympani nerve. Now, of course, just to be clear, the actual sizes of these nerves are not as I described, but this does give a conceptual framework for thinking about how the tongue is innervated. Okay, now that we've discussed and understand the final organization, we can take a step back and look at how this is the result of the branchial arch organization. Here, it makes sense that the first branchial arch goes on to become the anterior 2/3 of the tongue, because this is innervated by cranial nerves 5 and 7. Meanwhile, the third and fourth branchial arch become the posterior third of the tongue, being innervated by cranial nerve 9.
So a woman is pregnant with her first child and does not receive prenatal care. When the baby is born, a small sacral tuft of hair is noted. An ultrasound demonstrates an underlying defect in the dural sac. This presentation may have been prevented by maternal supplementation with a particular nutrient. Which of the following would be seen in an adult who is deficient with that same nutrient? Dermatitis, night blindness, hypersegmented neutrophils, numbness and tingling, or poor wound healing? You can pause the video if necessary and give yourself some time to answer this question. The answer here is C, hypersegmented neutrophils. Now, the first thing you should have concluded from this question is that the baby had spina bifida. The main clue to diagnosis is, of course, as I mentioned, the small sacral tuft of hair. This is further substantiated by what is seen on ultrasound, this underlying defect in the dural sac. Now, once you've made the diagnosis of spina bifida, you then need to remember which particular nutrient is given to mothers in an effort to avoid neural tube defects. The answer to this is folic acid. Folic acid is given as a supplement to mothers and reduces neural tube defects by 80%. This leads us to the final part of the question, which is what would be the effect of a folic acid deficiency in an adult? To answer this question correctly, you now need to rely on your knowledge of vitamin deficiencies and anemias. You should remember that folic acid deficiency leads to a megaloblastic anemia. You can review this in the hematology section. Now, in a patient with megaloblastic anemia, you would do a blood smear and you should see immature large blood cells as well as hypersegmented neutrophils. And that right there would lead you to the answer. Now, dermatitis is a part of a triad of symptoms, but that is seen in B3 deficiency. That triad of symptoms is dermatitis, diarrhea, and dementia. Night blindness, you should know, comes from vitamin A deficiency. Numbness and tingling you would see in another B vitamin, that it would be B12 deficiency. You should also remember that B12 can also lead to a megaloblastic anemia, which of course hypersegmented neutrophils are a part of. And then poor wound healing is again another hallmark of vitamin C deficiency. This question is a great example of how the boards will require you to integrate information. We started with embryology and spina bifida and ended in hematology and vitamin deficiencies. So let's move on to the second question.
A patient is seen in the clinic. He has an autosomal recessive disorder that resulted in a deficiency in tyrosinase activity in specific cells. He appears pale with light blonde hair and blue eyes, and notes that he sunburns easily and that his eyes are very sensitive to light. Now, the cells most involved in this condition are derived from which of the following germ layers? You may want to pause the video to answer the question. Now, as with the first question, the first step in this question is to make the diagnosis. All of the symptoms described point towards albinism. You should know that albinism is due to a problem with melanocytes. Specifically, there's a deficiency in tyrosinase, which makes melanocytes unable to produce melanin from tyrosine. So no tyrosinase means decreased melanin. So now the main thing to figure out is the germ cell layer that melanocytes are derived from. You should remember that the melanocytes are derived from neural crest cells and that they develop from the neuroectoderm. And that is your answer, C. Now, ectoderm develops into the skin as well as the CNS. The endoderm is responsible for a number of different organs, including the gut epithelium and some organs like the pancreas, the liver, the lungs, all of the non-essential organs, the organs you don't need to think. And then the mesoderm is responsible for muscle, bone, connective tissue. And lastly, as I mentioned, the non-neural crest part of the neuroectoderm goes on to develop the brain and the spinal cord.